All right, well, my disclosures are as listed. As we're waiting for this to load, I think it's a reasonable question to ask about focusing on prevention of ulcer recurrence. We heard yesterday from Dr. Jaff and today again from Dr. Sullivan about the astronomical costs of patients with PAD and CLI. So certainly one of the things that contributes to cost is wound recurrence and hospitalization and all the things that come associated with it. So although not at the top of the food chain of evidence, sometimes case studies help teach us a learning point. So an 82-year-old diabetic lady comes in with bilateral midfoot collapse due to Charcot arthropathy, also with partial first-ring amputation, so grossly abnormal pedal mechanics, and midfoot ulceration present for a month, clearly an unhealthy-looking wound. And when we look at this lady from a non-invasive perspective, she clearly has PVR evidence of PAD with decreased AVI. So that certainly merits further investigation. So my partner, Dr. Shishabor, intervenes with popliteal artery intervention and obtains a reasonable result, resulting in direct inline flow through the anterior tibial angiosome. So having had an ABI of 0.56 now doubles that to 1.12, and actually, unfortunately, though, still has persistent disease in the posterior distribution. But we thought that that would be reasonable based on wound location. So after having had intervention, we can do some sharp debridement and enzymatic debridement, and along with non-weight bearing. And she was very compliant with the instruction for non-weight bearing, so much that she stayed off her feet and improved the wound a few weeks later, but unfortunately was in bed consistently without any offloading device and then developed pressure ulceration on the heel. So we haven't even been able to fix the target wound, and now we have a second wound to deal with. So acknowledging that it unfortunately declines over the course of a few weeks, we have to go back and re-intervene on this lady, again keeping in mind this angiosome approach to perfusion, acknowledging that there's still deficit in the posterior tibial angiosome. So he goes back in and recanalizes the PT to have direct continuity through a pedal arch with a nice blush to that heel region. And now we're able to facilitate healing of that heel ulceration. And of course, true to form, none of these are easy when it comes to the heel. That porous adipose tissue does improve clinically over time, but unfortunately radiographically demonstrates some early changes of calcaneal osteomyelitis. So we treat for infection as well, again, with appropriate local wound care and offloading. And then over a course of many, many weeks, we're able to achieve complete healing. And at a year follow-up now, we've been able to keep her without recurrent ulceration. So how do you keep a patient like this with complex disease from recurring? Well, if we look in the literature, there's a number of papers that go all the way back to the 80s from Andy Bolton and his group talking about foot pressure and diabetic neuropathy, and this certainly can apply to patients with PAD and CLI, as there's a lot of overlap in these populations. But we know basic points that high pressures are associated with first and recurrent plantar ulcers, and certainly abnormal pressures precede the appearance of neuropathy as well as wounds, but these pressures help to predict ulcers. And then also certainly the presence of callus in the setting of high pressure can predict ulcer formation. So fairly intuitive concepts, but certainly confirmed in the literature. So when we think about the diabetic foot in patients with PAD, we look at things like plantar pressures, and we know that wound locations correspond to those increased plantar pressures. So a group, the working group on the diabetic foot, produced this paper a couple of years ago that was very interesting, looking at different strategies to offload pressure points and heal foot ulcers in diabetic patients. So this was a systematic review. So they looked at two separate systematic reviews, meta-analyses, 32 randomized controlled trials, 15 other controlled studies, and over 120 non-controlled studies, all published since May of 2006. And they looked at different interventions to help reduce plantar pressures and prevent wound recurrence. And those interventions were categorized into four areas of casting, specific foot care with modifications, surgical strategies, which we're going to hear about, and then other offloading interventions such as knee scooters, wheelchairs, crutches, those types of things. And they came to some very basic conclusions when they looked at this wide body of evidence that the best available evidence supported the use of non-removable devices for the healing of neuropathic plantar foot ulcers. So we take the patient out of the equation, if you will. But there was also high-quality evidence that supported the use of therapeutic footwear, which demonstrated reduction in plantar pressures and consistently worn by patients. And that, again, resulted in decreased foot ulcer recurrence. So keeping those data points in mind, how do we address these feet? Well, certainly we look to protect them in the acute phase, even before intervention, and we can use things like rook boots and rook mitts in the upper extremity to protect them from further tissue loss. And then certainly we have to think about that when they're in the hospital using things like heel offloading boots, those types of things to prevent further tissue loss, such as was pictured by the first patient. And certainly we all think about getting these patients mobile as quickly as possible, but unfortunately the little footy socks we provide to them in the hospital are not good enough to reduce pressure. So if they have custom footwear, it's important to ask family members to bring it in so that they can get up on their feet after having had intervention. Now, what about after that acute phase, transitionally, when they're moving toward complete healing? I put some pictures here of a variety of different devices that are available. The two on the left, fairly historic, the first being a heel weight-bearing shoe and then a heel offloading shoe. And you can just appreciate the nature of these devices, how unstable they would be, especially for our patients with significant arterial disease, neuropathy, and otherwise. So perhaps not the best choice in terms of increasing fall risks. The literature would support things like total contact casting for a number of these patients, and that's not an unreasonable thing to do, but sometimes the presence of ulceration with concomitant infection makes that a challenge as well. So when it comes to choices of other offloading devices to reduce ulcer recurrence, the choices are based largely on ambulatory status and the targeted pressure points. We can use a wide variety of foot orthoses and ankle foot orthoses. We can make modifications to shoes. There are a variety of different relief boots and wedges, and then advanced custom devices. So an example of some of those custom molded accommodative orthotics are of a total contact design to provide appropriate relief of pressure-based areas. And there's a wide variety of materials that's based largely on body habitus and patients' walking activities. I put this picture in, though, because it's kind of interesting. You can see that not all orthotics are created alike. This is a patient who has a very gross difference in the appearance of his feet. You can see architecturally his right foot has a decreased medial arch with some evidence of chronic Charcot-arthropathy compared to the left foot with a preserved medial arch. And I don't think you need to be a podiatrist to appreciate the difference in the feet, but unfortunately this patient had seen a local orthotist and was put into these devices. And I think that you can appreciate that these look almost identical despite the fact that his feet have a grossly different appearance from side to side. So even if we write prescriptions for orthotics, they're not all created alike. So making sure that they're fabricated correctly is of the utmost importance. We can also make modifications to shoes. We can put things like rocker soles and metatarsal bars. We can also remove the sole that corresponds to previous ulcer locations and replace with more forgivable materials to reduce plantar pressures. Now, when it comes to patients who've had partial foot amputations, we have to get a little bit more clever with our offloading strategies. So again, orthotics come into play with forefoot fillers as well as wedges to help facilitate propulsion. And again, these are of multi-laminate design. Those different colors represent different densities so as to reduce pressures, but also provide structural support to the foot for propulsion. Now, when it comes to patients with even more proximal amputations, such as pictured here at the level of Chopard's joint, this patient actually is a restaurant owner and complains of ankle instability as well. He's had recurrent plantar pressure ulceration. So in addition to his foot orthoses, we can also place them in these plasticized braces. These are short leg articulated ankle foot orthoses. So it offers all the accommodation to reduce pressure, but also structural stability to support the hindfoot and ankle joints. And with these, they fit into shoes and he can walk fairly well. So when it comes to preventing ulcer recurrence, we see patients for routine podiatric care. And sometimes these fairly mundane complaints like mycotic toenails or corns between the toes or tinea pedis or callus debridement offers us the opportunity to see these patients, to do screening for recurrent arterial occlusive disease, and certainly to try to head off things of the past before they get to the point of recurrent ulcerations due to ill-fitting shoe gear, to catch things like Charcot-arthropathy and biomechanical faults so that they don't have concomitant ulceration as well. So those routine visits become critically important to preventing wound recurrence. So in summary, to prevent ulcer recurrence from a podiatry perspective, certainly perfusion monitoring comes into play, at least with pulse examination. That's something all of my podiatry colleagues ought to do. We also spend a good deal of time looking at custom orthotic footwear to accommodate structural abnormalities and reduce plantar pressures, as well as reduce shear on the foot. And then, of course, reinforce basics like daily self-foot inspection and routine follow-up with regular podiatric care. And we've heard this from many, many speakers, from the guidelines. Certainly it takes a village to take care of these patients to prevent ulcer recurrence. It's been a pleasure to share the podiatrist perspective. Thank you.